Welcome, everybody. We're going to give everyone a few minutes to log in, and we will get started here shortly.
Hey everybody, good evening and welcome to this presentation from the Society for Advanced Bronchoscopy. This talk is sponsored by Philips and it's entitled Implementing Cone Beam CT Scan and Augmented Fluoroscopy for both Biopsy and Ablation. I'm really pleased to have Dr. Sharma here, who's the Director of Interventional Pulmonary at Columbus Regional Hospital, to do the first part of the talk, and then I'll be back with you at the end. I definitely want to encourage everyone to submit questions throughout. There's a questions box on your bar on the right. Submit those and we'll try to hit all those questions at the very end. We're recording this and this will go on our website. For those of you that are members, you can view that later. And remember that we just dramatically slashed our prices for membership because we want everybody to join and be a part of this. So without further ado, I'd like to introduce Dr. Sharma to kick it off for us tonight. Thanks.
Thank you, Michael. Good evening, everyone. This is Deep Sharma here. I just wanted to hop in and just say hi, and then I'm going to shut down my webcam, and then we'll take the presentation from here. Any questions, please feel free to chime in the end or while the presentation as well. All right, so for disclosures, non-relevant to this presentation. Just a quick background. I did my residency in Baltimore from From there, I went to Wake Forest for pulmonary critical care fellowship. Did my dedicated interventional fellowship at VCU with Dr. Shepard and Dr. Shoji. And then straight from there came to Columbus, Indiana to start an interventional pulmonary program. The hospital has been around for 104 years, small to mid-size, about 225 bed, but has a high outpatient volume with 10 counties worth of catchment area. It is one of the only hospital other than the critical access centers in a 50-mile radius. And the Indiana-Kentucky belt, as we all know, is a very high smoking, lung cancer, and chronic lung disease prevalence throughout. But despite all that, in general, in Indiana, there was a very sparse IP presence at that time. So seemed like a good opportunity to introduce some new technology and treatment modalities here. Apart from me, we have 3 other pulmonologists in the group, 5 APPs. So as I said, not a huge hospital or a department, but that's not what is needed always to have a viable interventional program. So we're going to focus on the peripheral lung nodule part for the sake of this presentation. So the equipment that I had, or I inherited when I first started here, was a Super D V7, approximately, I would say at that time 8 years old, at a portable C-arm, radial EBUS, and that's what I had been used to for 4 years of my training. Our initial volume was about 300 procedures of total and about 70-75 navigation bronchs a year. Hybrid OR was under construction and was being constructed to promote our vascular surgery EP, and then there were some talks about structural heart program at that time. And then when we just started having discussion about it being used for the pulmonary procedures, it was an unknown concept. I did not have even a single person who was aware of that. So the reason I developed interest in the cone beam CT modality for diagnostic purposes was, few reasons. One was that prior to this, only real-time visualization or confirmation we get during our procedures for peripheral nodules were the 2-dimensional fluoro or the radial endobronchial ultrasound, which again is not there throughout. And because of these limitations, there was limited diagnostic yield with every virtual platform. And while having a very limited diagnostic yield, it still was a very resource-intense procedure, one of the most expensive equipment that we would buy as a interventional or advanced bronchoscopist. And there was always this dilemma in my mind about, okay, we put in all these resources and set up this program, and locally or in the literature, everyone diagnostic yield is between 60, 70, maybe 75%. Is it even worth it? Why don't we just keep doing what we have always done and have our IR folks do a TTFNA under better imaging and have a 90-95% yield all day? So I used to think about that a lot. And then with the 60, 70, 75% yield, it was clear that this was barely a decent diagnostic modality, and there was definitely no future in therapeutics with the limited accuracy. So this, all of us know, there's huge burden of lung cancer, and from last, I would say 10 years, the pulmonologists and especially the interventional and the advanced bronchoscopists have kind of come in the limelight, and we run the show around lung cancer at most of our institutions. But despite having that responsibility, the literature and the data that was out there showed that we still had quite a bit of limitations in what we were doing. So again, just running quickly through some of the landmark studies, we all know Acquire, which is by no means is the actual representation of the navigation procedures that were happening, but this was one of the early data that came out at such large scale and showed a diagnostic yield of like less than 40% with navigation, and only improved to 47% by adding radial EBUS. Navigate, again, 1,000 patient study, median size of 2 centimeter, and at 12 month, sensitivity was 69% and diagnostic yield was 73. SpinPerk was the virtual platform-based transthoracic biopsies, and in this study we had 129 patients, roughly size about 27 millimeter, and the numbers for the diagnostic yield same, around 73%. After that, we have had quite a bit of development in our navigating platform, with the robotics being the newest development in the last 3 years. So the benefit study, which was recently published, had a median size of 23 millimeter for their lesions. Localization was 96%, which is great, and was very well highlighted. But again, the relevance of localization without having a diagnostic yield is questionable, and the diagnostic yield was still 74%. Then there was a robotic assisted bronchoscopy for peripheral pulmonary lesion study, which came before benefit trial, and was one of the early studies for robotics, and included 167 lesions, average size about 2.5, and had a yield of 69 to 77, assuming how you count the negatives that were lost to follow-up. And then the last one was a precision study, which was a robotic-based study in cadavers, focusing on localization, but also actual puncture of the lesion, and for a 16.5 average size lesions, they were able to demonstrate 80% with the robotics and 45% with EMN. So clearly there was a lot of need to improve what we had been doing, and that's kind of what started all this in my mind, and I wanted to implement it. Also during my training, I'd been exposed to some of it. As I said, I was in North Carolina, so we used to have these multi-institution kind of teaching day with on advanced bronchoscopy. So from there, I heard Dr. Pritchard and was aware of the work he was doing. And then in last 2-3 years, I think the cone beam robotics and endobronchial valves were one of the favorite topic of every IP meeting or webinar. So that's how I heard most of the stuff that I knew at that time when I started my program. And as I said, I had no formal training in this. So the first step was to convince people that this actually is not a crazy idea. It can be a viable program and can add value to our patients. So I started having some administrative discussion. Again, in my experience, I think using evidence-based arguments is the best strategy, and being an advocate for our patients. But it's only a hope that the administration would care about it, because what we usually hear in response is the business plans or the return on investment, which I can tell from my experience from a physician standpoint, there is minimal change in per procedure revenue. Improved yield is the biggest goal, and then expanding the program and other downstream revenues and increased volume is how you're going to see the return on investment. But sometimes it becomes hard to convince others and share the vision that you have. From the facility standpoint, there's definitely much higher reimbursement for the procedures being done in hybrid OR. It can have direct impact on patients as well as the referral pattern, but it will involve some marketing, community outreach, and then also kind of showing your data and reflecting that. But as far as the referral base from your fellow pulmonologists and oncologists, again, if you go and tell them I do cone beam CTs, I would say 95 to 97% would not know what you're talking about. So it's a part of the program. It will help grow the program, and you have to assess everything, from 1,000 feet view, just like a Formula One car has multiple thousands of parts, and if you want to win the race, you have to look in the totality and not just one part. So while we are talking about billing, some CPT codes to remember, 76376, 377, which is the post-processing and segmentation on independent workstation. As you can see, very small WR view value associated with those. CT guidance for needle placement, and then tissue ablation. There are some documentation requirements for these. You have to make sure you describe the CT findings and make sure that you clarify that it was assessed on independent workstations and all that. But again, when I first started, I had a lot of coders and everything kind of look through and give their suggestion, which I disregarded, and that was one of my suggestions. Again, do not let anyone force feed documents or keywords into your procedural notes. Block time would be an issue, especially with at this point with multiple specialties fighting for that one machine and the one OR. So grab what you can get, and then as you show value and do procedure and the volume grows, it becomes easier to ask for more. So equipment is definitely one of the challenging part due to the cost associated with it. There are many options. If there's already one that you have, best would be to work with what you have, optimize, and then if you can have more specialties interested in it, then that would help to make a case for a newer hybrid OR. But just to have one exclusively for pulmonary procedure, at least in my case, did not make sense. I'm going to skip through this. Again, some basic comparison between portable C-arms and cone beam. We'll talk about this as we talk about other things. So before the first case, there's a lot of training and more of a self-training. So consider yourself as the driver of that Formula One car, and then everyone around you is your pit crew. So you have to drive, you have to have everyone get interested and run through these processes and read about it, learn about it, because otherwise it would be very hard to have everyone motivated or interested in it. So I started with my bronchoscopy tech, surgical techs, or if you're using your respiratory therapist, I use dedicated radiology techs to operate the machine. I had one by one all of them get trained. We started with a core group of 2 or 3 people, make sure they are confident, and then expand into others. Anesthesiologist is a big part of this because how they intubate and manage your patient can basically make or break your case, and I'll touch base a little bit more later. Pathologist the same way. I always had on-site cytology. I brought them in. We had to make a station for them, make sure they had the ventilation and all that. They had to wear lead and everything that they were not, because previously they were out of the room with the navigation procedures. So all that, those little details which matter, just make sure you run all these scenarios in your mind and have everyone trained and prepared for the case. Other things which are optional is proctorship. Have someone experienced come to your center, or you can go to their center. And these days everything's virtual, so that makes it a little bit easier. Or some of the companies also offer like training or sim labs. I just did everything kind of myself, and then made some models. I remember using a bed sheet and some Hershey chocolate, and then doing spin expert CT after expert CT, trying to localize and play with the software a little bit. So whatever works in your setting. So the reason anesthesiologists have a very important role is that the atelectasis, that one thing we were ignoring when we did not have this level of real-time imaging, seems to play a very major role. So what I do is go for straight rapid intubation, largest ET tube possible. We stop at 8.5. Lowest possible FiO2, usually about 30 to 40%, depending on what their functional or respiratory status is. Keep the patient paralyzed until you're done with the peripheral lesion part. Maintain moderate PEEP around 10. Little bit higher side of tidal volume. Ignore the ARDS-NET protocol for 2 hours or less. So maintain around 10 cc's per kg. And then when we're doing the breath hold, make sure you have the APL valve set around 25 to 35 to keep your lungs fully inflated. This is one of my cases, moderately obese person. Everything was done as per the plan. CT was obtained within like less than 5 minutes, and you can still see atelectasis in the basilar area. And if you have a ground glass or a small nodule in that region, then good luck localizing that. So one of the things that I personally got confused all the time was the terminology. So talk to the team that is helping you setting up. This is expert CT, where you're gonna do a spin and obtain CT slices. This is expert guide, where you can mark the lesion in 3 dimension and what is called a segmentation. This is CT augmented fluoro for the Philips system. Is the name is EMBO guide, where you mark the lesion, and then when you project or use your fluoro, then it projects the shadow or the 3D image of the lesion on the other screen as well. And then this is the 3D overlay, which is my favorite view, which is, this is not available in the suite, but it's on that independent workstation. And then it gives you like a good 360-degree view of the lesion and where you are relative to the lesion. Again, comparing the 3 views, starting from the left is the CT augmented fluoro, there's a 3D overlay, and then there's an expert guide with the, right now it's showing the tool in the lesion. Quick 10-second video on how the 3D overlay looks and why is it my favorite view. As you can see, it exactly tells you where you are, and you can look at the lesion and the relation to the catheter from every angle, and that will definitely help make adjustments. This is where I am right now at my center. I have the Philips Azurion 7 C20 Flex Move. I have the EMBO guide software, and then last few months we have the low dose expert CT capability as well. I'm still with my Super D V7, which is I think now 10-year plus old. Still have the peripheral EBUS, which is an absolute must in my opinion. And my procedural flow runs through a patient, coming in, getting position, make sure the left and right, so keep your lesion towards the center. Again, rapid intubation, do the airway inspection, registration, use the navigation system to get to the lesion, use the scope holder if you are able to, and then breath hold, and then get the expert CT. Now I have the low dose protocol available, so I use 25% by default, 50% for obese people, and then 100% for the ground glass lesion, or if it is in the atelectasis prone areas of the lung. Do the 3D segmentation at the independent station, and then come back in the room, start the CT augmented fluoro. So one screen is showing the augmented view, one is showing the plain view, and then I use the AP, and then I tilt it right anterior or left anterior, and then get another view to make sure that I'm right in there, and then I personally am a big fan of peripheral EBUS, so I use it in every case to confirm my location, because the fine tuning between the concentric and the eccentric, I think that still can improve if you're using the peripheral EBUS. So I use that. My instruments, I use FNA. So I have 18 or 21, triple needle, and then the transbronchial forceps, and I have on-site cytology present in all cases. Some of the small things that helped me, or at least would have helped if I would have thought about that, was again, start with a straightforward case, large lesions for at least 1 or 2 cases or 3 cases. I was trained to start with the lymph nodes, and if you get an answer, then you don't have to do the navigation. Here it's kind of reverse. You start with the navigation part first, and then if unless there's something obviously positive in the mediastinum, then of course we don't need that. But always start with that, and then make sure your time from intubation to 3D segmentation is as less as possible. Scope holder has been an immense help. So you're not trying to support your scope here and there on the pillow or somewhere else while you're out of the room. As I said, I have huge respect for peripheral EBUS. And then my favorite view is kind of the oblique view, and I'm not a big fan of the lateral view. This is how my scope holder looks like, not endorsing anything, just what worked best for us. Learning curve is very user dependent. I would say for all of us, on average, would be 10 cases, and then use whatever downtime you have to simulate on your own. When you start doing these, the first reaction you'll see is like how much the navigation of the virtual platforms versus the real-time differences. So this is one of the real cases I did. That's the navigation screen that shows me I'm right in the center, but then you get the CT and you're like way far, and then you re-navigate or readjust, and then you get back in the lesion. Another, many examples of the cases. The bottom 3 augmented fluoro, that's the right anterior AP and the left anterior oblique views, just to show how you can get the orientation of your catheter compared to your lesion in different views. Again, data is the most important thing. Make sure you have a plan to collect the data from starting from case 1, and you know what are the indicators you're going to be tracking. You can do it as part of a single center versus multi. My study here, which is the goal was to compare addition of cone beam, because everything else remained the same. The bronchoscopies, the Super D platform, radial EBUS, and then only thing that changed was from 2D fluoro to cone beam. And the primary goal was to look at the sensitivity and diagnostic yield. So I had 86 patients or lesions with the EMN with 2D fluoro, and 90 lesions with EMN and cone beam CT arm. Average size of the lesion was 2.6 in the 2D fluoro, and then 2.4 centimeter for the cone beam. Overall diagnostic yield improved from 87% to 94%, and then overall sensitivity increased from 77 to 92%. If you look at the size-wise yield, the less than 2.5 centimeter lesions, we increased from 80% to 90%, and sensitivity went up from 61 to 85. And then for the smaller lesion, for less than 2 centimeter, we went from 77 to 87, and then sensitivity jumped up from 57 to 79. So that was a pretty significant change for me. I'll just run through the studies. I'm way behind time. So these are the few of the studies that I had wanted to discuss. I'll just discuss go through the recent ones. So from Dr. Casal's study, 20 patients, diagnostic yield was 50, and then adding cone beam CT went up to 70%. Dr. Pritchard's study had 93 lesions, and then average size lesion at 16 millimeter, and then his diagnostic yield was 83%. Faiz, he did his, I believe this was published this year. Again, median size was 16 millimeter for the cone beam group, and then yield was 74% compared to 51. And then the last one, again, was published this year, was 52 patients and 59 nodules, mean diameter less than 2, and then overall still 86% of diagnostic yield. A couple of big things, and where I think the future of cone beam is the airway mapping. And then this was a study that was again published this year in Journal of Bronchology, showing localization success of 96% and diagnostic accuracy of 88%, where if we, the way you mark the lesion, you start marking the airway, and then you're not dependent on any kind of navigation platform to guide you there. This was again just to show how important the ventilation protocols are, and then how it affects your yield. So the usual protocol versus the dedicated protocol for cone beam CT, and you can name it whatever you want. I think Dr. Pritchett calls this Pinehurst protocol, affected the yield from 70% to 92%. So again, radiation exposure is not a big deal. It's actually less than many of the other modalities we use. And the ways to reduce is you can collimate, where you are focusing on one part of the lung. You can reduce your contrast, so which reduces the X-ray dose, or you reduce the X-ray dose, which reduces your contrast. You can use the lower frame rate, so from 7 or 15, you can go to 7.55 frame per second, or even lower. You'll have some lag, but it, in my opinion, is totally workable in the second half of the procedures. And then the low dose protocol, of course. So this is the summary slide that I stole from Dr. Pritchett. Shows different studies, and then my data here, we had 1.15 scans per case. Total effective dose was 3.8 microsievert. And the reason it's lower, it definitely got lower with the low dose protocol, but also when I added the EMBO guide, and I did not have to do the second spin. Future modalities, for cryobiopsy, I've used it. I've done at least 5-7 cases where there's patchy disease, helps localize and give you confirmation that you're in the right area. TTFNA, this is again one of the models. You can see the real time versus the augmented, the needle's right in the lesion. This is integrating robotics into the cone beam, and I understand most of the people here already have robotics. I'm way far behind in that. On that front, I was focusing on cone beam, but that's the future goal, at least for me, is to combine those two technologies together. That picture is again Dr. Pritchett with his intuitive system. Airway mapping, this is one of our real case I did. If there's any trouble getting the EMN part approved or anything, used to be like a peer-to-peer and this and that. Now I don't even care about. I say, okay, if they're not approving, that's fine. I just use the airway mapping feature, and then just use that to reach the lesion. So saves time, cost, obviously effort. Prone bronchoscopies, I believe this was also published recently. Again, to overcome atelectasis and give you good real-time view and access. And then all this while continuing to reduce the radiation exposure further and further. So you can see the 3 CTs, the one on the left is the 100%, then 50, and then 25. And then even though you can tell subtle differences, but nothing big to hamper the yield. And then lastly, again, I think the next step would be to go more and more into therapeutics and ablation of the tumors, which I believe Dr. Pritchett is going to talk about. That's all I got.
Thanks so much, Deep. That was a fantastic talk, and thanks for showing us really how to build a program from scratch, and that's fantastic what you've been able to do there. So congratulations are in order. I'm going to talk a little bit about therapeutics, and then and integration with cone beam CT scan. Here are my disclosures. I'm pretty equally biased across the board for the most part. So, as Deep said, there's some limitations there with this current system. Will robotics add an advantage there? We're in the process of seeing that, but we certainly see early indications that there's advantages there with the stability and the reach of that. So this is a picture he showed. This is us doing our cases here in our hybrid OR. This is also, my system actually is about 11 years old. And Deeps is brand new. He's got the Ferrari system there. Maybe to make an F1 analogy, I'm in like the Haas cars or something like that. But it really evens it out because it's all about software. And so I have the exact same software that he does. And so we're able to do all the same things. And that's what's exciting. So this is what it looks like to do a cone beam scan with, in this example, we have our ion robot that we're using. So it takes 8 seconds. We have the anesthesiologist there behind the shield, and that's it. And as soon as we get that scan, then we're able to look at this and segment the lesion with these multiple views. So augmented fluoroscopy puts the lesion on your fluoro. And so no matter what angle you put that C-arm in, you've got it. And it's very important to look at that in multiple angles. So here from AP, it looks like I'm right on it. But if I look at a more lateral view, I can see that I'm actually slightly posterior to it. And this is where the advantage of robotics comes in, is because I can look at my graphical user reference and say that way is anterior. I move the trackball very slightly that direction, and there I am right in the lesion. I can do another cone beam spin. And this is the kind of accuracy that you really need to successfully do ablation. That's why I'm talking about this before we get into the ablation part. You also want to confirm that in all 3 planes, just the same reason that you want to look at it in multiple views. This is another example of kind of the combination of these 2 things with a robotic catheter that's 3.5 millimeters, can go all the way out to the apex pleura, and we can see the lesion. We can combine that with this if we want to do a tool in lesion spin. And we also have vision out there as well. So we can see the airways and know when to turn right and left and things like that. So there you can see some mucosal irregularities there all the way out to the pleura. So this system has great vision, and then you perform your biopsies there and you get your diagnosis. This is what tool and lesion confirmation looks like, and we strive to do this with our biopsies, and we want this to be kind of the new standard. This is basically like a CT guided needle biopsy. You can see your tool in the lesion, and that really helps us with benign disease. And when you look at these clinical trials and you interpret the data, you want to, the devil is in the details of the benign disease. Malignancy is easy, so we want to clearly define the benign disease. And so when my pathologist tells me, hey, this kind of looks benign, I definitely want to do another spin with cone beam and see that my tool is in the lesion that I didn't just miss. Here's our data that we're submitting. We've got 230 lesions consecutively that we biopsied, and our diagnostic yield. This is using the same diagnostic yield from recent benefit trial. So you can kind of compare apples to apples. And yes, this is cheating. I'm using cone beam, but I'm cheating on behalf of my patients, so I don't care. Median lesion size, very small, 15 millimeters. And even for lesions 10 millimeters or less, we have a lot of success with these. And our pneumothorax rate is only 1%. So are you ready for ablation? These are the questions that you have to ask yourself. And I think a lot of people think that they're ready for ablation, or they're being told by different companies that maybe they're ready for ablation, but there's a lot of things that you have to figure out first. And so these are the questions that I kind of want you to ask yourself and your reps and your hospital and things like that in order to figure out if you're ready for it. So number 1, it sounds really silly. Do you have cone beam CT scan? That's a really important part. Before you sign up for a clinical trial to do ablation or whatever, you've got to have cone beam. And there's more questions beyond that. What system do you have? And that's important. And you'll see some of the kind of different footprints of some of these systems. Do you have access to it? So Deep mentioned that they built this as a vascular OR, and so a lot of hospitals have these systems. You may just have to look around or ask around and find them, and then get some access to them. The guys at Vanderbilt, Otis and Fabian, found a system, and they come in every other Saturday to do cases. And that's how dedicated they are to advancing the space and moving forward. And so they got access to their Philips lab every other Saturday, and they put their hardest cases on that day. So are you considering buying a system? So you may not have a system already. Are you going to buy one? Are you going to buy a portable system? Are you going to buy a fixed system? Are you familiar with the differences between the systems? Because there are significant differences between the systems. The cool augmented fluoroscopy, that blue dot that you see, you don't have that with a portable system. You get the augmented fluoroscopy because the bed is tied to the C-arm, and those things talk together the whole time. You also have a significantly longer acquisition time with a portable system. You have to do those deep breath holds with high PEEP for over 30 seconds. The spin takes 30 seconds, but it takes a few seconds to prep it first. And also you want that time for the lung to equilibrate. Whereas cone beam scanners are scanning in 5 to 8 seconds. So just make sure that you vet everything before you buy a system. And is it compatible with your current navigation system or maybe the next navigation system that you're thinking about buying? Because not all these things work quite as well together. There's varying degrees of kind of compatibility. And lastly, do you have experience using your cone beam CT scan with your navigation system? So before you can be a site for a clinical trial or anything like that, you really need to have experience. You can't have your first cone beam case be your first case with your new robot or your new other navigation system, and you certainly can't have your first cone beam cases be your first ablation cases in a clinical trial. So you've got to show that you've got that experience and dexterity with that, because there is a learning curve. Deep did a great job of pointing out how he overcame that learning curve, not just for him, but for his staff, for the nurses, for the respiratory therapists and anesthesia and your radiation techs. All those are very important, but with the help of proctors, and you don't have to do it by yourself like he did. We do have proctors. We can come out. We can help you with this. And so now, Philips has that infrastructure. Do you have a clinical trials team? You can't really do clinical trials unless you have a clinical trials team. So all these things are things that you want to ask about, establish, so that you can get in on this, because ablation is not going to be off the shelf. Just buy an ablation catheter and throw it in a patient anytime soon. I hate to disappoint people with that. There are clinical trials that have yet to start with multiple companies. So we have Medtronic and NewWave here in the US that are kind of vying for this. And we'll talk about some of the data, and I'm going to show you some examples from some cases that we've done, but we're several years away from being able to just grab an ablation catheter off the shelf, throw it in a patient, and start ablating. So all this is going to be early clinical trial work with lots of follow-up. You saw this picture earlier, and I kind of want you to imagine these systems and imagine where your system's going to be, where you're going to stand if, for example, your system is mounted at the head of the bed. What's going to happen to your robot or your Super D machine or whatever when this thing spins around? And then on the bottom, you can see the examples of the different augmented fluoroscopic technologies that come with each system. So again, you saw this. This is from a little bit different angle. This is what it looks like from the head of the bed. And you see there's zero interference with my robot. It's not getting in the way. It's not doing any crazy spins. The arms don't have to be over the patient or anything like that. So this really stays out of the way. Watch this. This happens fast. This is a Siemens Dyna CT scan. And again, you have to think about where you're going to position yourself, your robot, your anesthesiologist, and is there room for that with whatever system that you may have. So let's talk about ablation. The first in-human ablation with transbronchial, that's the correct term for it, not really endobronchial, but transbronchial microwave ablation was with Medtronic, and that was done in the UK. This is actually a picture of that. I was very proud to be there kind of helping out with the Philips part of this, and this was Dr. Kelvin Lau at St. Bart's in London. And he completed a small series of patients, really just kind of safety and feasibility. And this dear patient over here was the first one to have that procedure. And then a little bit later that year, we did the first in human with NewWave. NewWave is now owned by Johnson & Johnson. So this was one of the cases, and I'm going to get into the details with that. We were proud to have a great group of people there, had some of our friends and colleagues from Cleveland Clinic and some other places there. We had an interventional radiologist with us, Dr. Paul Lasky from University of Wisconsin, at all these procedures, and his advice was invaluable as he's done this percutaneously in thousands of patients. So I have to read the disclaimer. The images and the cases that I'm going to show you are from the clinical trial that we did with NewWave. There are a total of 11 patients that were treated between here and the Mayo Clinic in Rochester. Dr. Janny Reisenauer and Dr. Ryan Kern did the cases there. The study is closed and the device is only being used under research protocols right now. So this was probably the third case that we did, this right lower lobe lesion. This is what it looks like when you initially do this, what we call segmentation. That's with the cone beam. And then we see this augmented fluoroscopy. So we're watching live augmented fluoroscopy while I'm putting the ablation probe out there. And so you can see how invaluable this cone beam assistance is to us. This ablation probe is with NewWave, and that's kind of a very sharp tip. And so it doesn't actually need another tool to cross the airway wall or anything like that. So we can pretty successfully get into small lesions without having to use any additional materials. But that's what it looks like. And then we can get all these cool views. This is all the software that's built into this, which was really designed for ablation. And so we get this estimated zone of ablation, and we can see what that looks like. And then here's our post-ablation zone. So this is on a cone beam CT. So after we're done, we wait 10 minutes, and then we do a cone beam CT scan, and we can see that zone of ablation there. And we can measure that in multiple planes and know exactly where we treat it. So this is what it looks like pre-ablation and post-ablation. You can see that some of the target has been vaporized a little bit. That happens sometimes. And you can see the very fine line of ground glass around that. That's another reason why you need a cone beam system with excellent spatial resolution so that you can see these very subtle details. And we've shown that we can do this even with significant dose reduction. So this is what the progression looks like, and everybody's kind of ablation zone looks a little bit different. This patient had a little bit thicker wall at 1 month, but you see very quickly this shrinks down into almost nothing after 12 months. Here it is in the sagittal view. Here's the next case, and this is probably our 7th or 8th case, a right upper lobe lesion. Now I'm in the lateral position, okay? So these anterior lesions, it's fantastic to be able to use a lateral position. And I really need to make that video play. How can I do that? Anyway, it's not going to play. But that's putting the ablation probe out there with augmented fluoroscopy. And here we see, again, I didn't have to use a dilating tool or cross-country tool or a balloon to dilate the airway or a large needle. That sharp tip is able to punch through there, and we can get our tool right through the center of this lesion. Here's why it's important to look in multiple planes so that we can see exactly where we're at. So even in one plane where it looks like you're perfectly through the center, you need to look in the other planes. This is a 3D procedure. You have to think about this in 3 dimensions. And so this is what it looks like when we superimpose that, and we can kind of spin this around in 3 dimensions. You saw how Deep showed you that video earlier where we spin it around in 3 dimensions, and that's what we see. This is ablation zone planning. This is part of the lung suite package that comes with Philips. And so the blue circle is the lesion. The green circle is the ablation zone margin that I typed in that I wanted, and I just put an arbitrary 8 millimeters. We want something between 5 and 10 millimeters. And then we set 2 factors on the ablation system. We set the time and we set the power. And the Philips system knows what the estimated ablation zone is for each time and power. And so that's what that red circle is around there, that you can see that. And so there you can see the estimated ablation zone. And again, we need to look at this in multiple planes. So we know that we're going to get this in all 3 planes. And so this is what that 3D looks like. We don't want any of that blue lesion sneaking out of that red circle. Okay, so there you can see we've got it perfectly in the middle, and we can spin this around before we do the ablation and make sure that we're in the right spot. So that software there is invaluable. And this is what an ablation zone looks like in this case, 10 minutes afterwards. You can see the measurements there. And those measurements are our ablation margin. And you want to check that also in multiple planes because that will change. You need to consider whatever your smallest margin is in all 3 planes. That's the most important measurement. So this is what that case looks like over the course of 12 months. And we've followed these patients now. This is 2.5 years, and our patients are doing very well. Here's another case, and this is a case where we did multiple ablations in the same case. And I'm going to show you, that's a technique called bracketing. So here we did this with superdimension, and you can see I'm positioning that ablation probe with augmented fluoroscopy in a lateral view to get that into position. And then again, this was the best we could do. So this was a limitation of the catheter, and that it deflects with tools and it would straighten out. This is something that we hope that the promise of robotics will help us do, so that we can put the catheter at any angle we want and it will stay there and not have deflection. So here we were not able to get right in that. Now this was a little bit bigger lesion. This was 2 centimeters, right at the upper limits of what we were allowed to treat in this trial. So we said, okay, we're going to do some bracketing on this, meaning we're going to treat one side and then we're going to treat the other side. So this is what our ablation zones look like. And again, you need very high resolution, which these systems can give you to see this. We saw this little area here where there was this little invagination that showed us in the sagittal plane that on the superior edge of this lesion, we were going to have a close margin. So we just repositioned the ablation probe and we did one extra touch-up treatment right there. So there you can see what it looks like. And then we have 3 overlapping ablation zones perfectly around this lesion. And this guy did fantastic. This was a mucinous adenocarcinoma. It was not a surgical candidate. He had lots of heart problems. And look at this lesion just completely shrink down. This is actually over 18 months, just completely shrink down into a scar. And you can see this through multiple planes. And this is the data that was presented at CHEST this last year, looking at 10 patients that had the original, and then actually I treated a second lesion in patient number 1. She got a second isolated lesion in a different lobe, and that was treated later. You can see the lobar distribution. The majority were in the right upper lobe, but we treated a lesion in every lobe. Upper and lower. And so out of 11 cases, we had 100% immediate success, which is technical success, and 30 days post-ablation success was there as well. No evidence of local recurrence in the patients at 12 months. We did have a patient that was treated at Mayo that died several weeks after the treatment. The cause of death is unclear. Likely a cardiac event. Had significant comorbidities, and so that was part of also what kind of slammed the brakes on things and had the FDA look closer, and why we're reworking these studies to do things differently. And we're now doing these the way that the FDA wants us to, which we were before. That was FDA approved, but now we've changed. And the next trials are going to be with metastatic lesions first, and then moving on into primary lung cancer. What's the effect on lung function? The cool thing is that we had no significant difference in lung function. In fact, if you look at these numbers, people's lung function got better. And so that's a pretty cool thing. And we're just putting the final touches on this manuscript right now to submit. And we're going to have more extensive data there for you from that standpoint. But there's no deterioration in their respiratory function at all. These are some of my patients. Don't worry, they agreed and signed releases to have me show their pictures. And all of these patients have been treated. The patient on the right of the screen was patient number 1 and patient number 11. I treated 2 lesions in her. The woman to my right was the first case that you saw. And the gentleman to the left is the middle case that you saw. And that's what we have to remember that this is all about. So I know that we want to get really excited and start doing ablation, but we need to keep all those things in mind. So with that, I'm going to stop. And let's open this up and see if anybody has any questions. Emily, you can take the screen back, and I'm going to look here and see if we've got any questions. Again, feel free to throw these in the box, in the chat box there, so that we make sure that we get all your questions answered. And Deep will be back on with us here too. So how does the cone beam CT scan impact the total procedure time of your workflow? And I think that's a great question. Deep, can you answer that question for us from your standpoint? How do you think that this has affected your total procedure time?
Yeah, absolutely. I personally, without having any hard data to compare before and after, anecdotally, I think it definitely shortens the procedure time, and definitely shortens the anesthesia time, because we have shorter time to localize the lesion, and then we have good visualization right away to tell if we are in the right spot or not, without doing 5 passes and then waiting for on-site cytology to tell us that they're not seeing anything. So I think with all those limitations much significantly reduced, we are able to figure out if we are in the right spot. If not, make adjustments, which kind of takes the pain and the time-consuming part of the out of the procedure.
Yeah, I agree. From our standpoint, again, I don't have data because I'm not going to randomize people at this point and say, okay, because like kind of once you've seen the light, you don't necessarily want to do a trial to slow you down. But yeah, I think that it actually speeds us up. And when you get your team down, all I have to do is say, we're going to do a spin. The non-essential people know they need to leave the room. My rad tech sets things up. Anesthesia is ready to do a breath hold. And we can do all that in about a minute, where we clear the room, do a breath hold, set up the cone beam, do the 8-second spin, and then within 2 minutes, I'm back to the head of the bed making decisions based on that information. So I think it actually makes our cases faster. All right, next question. How easy was it for you to get access to this technology? And any tips for a clinician looking to start using cone beam CT? I think that's a perfect question for you, Deep.
Yeah, I mean, same thing as I said before, at least few years back, this was again not a very well-known concept of combining cone beam into a pulmonary field and for diagnostic purposes. So I think things are much or relatively easier now with so much data already out there. I would say for me, 3 years back, it was tough, and it took some discussions and have people look into it, read about it. And at that time, there was also limited data. So, I'm glad my administration, took the leap of faith and supported it. But at this point of time, I think there's so much data out there, and that this seems to be the future. So it should be relatively easier now. And as far as the tips, I would say, leverage whatever you have, come up with the data, come up with a plan for comparative studies, involve the business people to look at the facility generated revenue collections on these cases, and then also try to convince how it improves or grows the program, how it feeds into the thoracic program, how it feeds into the radiation oncology program, how this can be fed having a lung cancer screening program. So it all kind of like, it's all a big web that you form around and look at your program like that.
Okay, fantastic. We've got some other questions here. I'm having some technical difficulties. I'm having trouble seeing the questions. Here we go. How steep was the learning curve to get started using your cone beam CT system?
Not too bad for me, Mike. As I said, again, depends on how technically challenged or savvy you are. I think the system that I have was, and the software part was very intuitive, and I started with the expert CT part, and then after 5 cases we got the EMBO guide software, and then after a few cases we got the low dose protocol. So for me it was kind of like a step up, and it gave me some time to adjust. But I would say after first 4 or 5 cases, I was comfortable that we can just do these cases very efficiently, and there's still room for improvement. I mean, even at my 120th case, I'm still learning and improving, but I think the biggest slope kind of is for first 5 cases, and then you get a good hang of it.
Yeah, I think, my answer to that would be very different because I had a very long learning curve. because we were kind of just trying to figure this out from its infancy. And so we didn't know what we didn't know, and it took us a long time to figure that out. And that's a big focus of what Philips is doing and what we're doing as far as helping to proctor people. So now we're getting places up and running with the help of Philips, and having people on site and having techs that can come out for your procedures and having docs to proctor. So the learning curve now is dramatically shorter. You can really be up and running very quick. I think a great example is Dr. Jerry Kreiner. I went up to proctor his cases. Those were his first ion robotic cases and his first cone beam cases. He did 3. I came back the next week, he did 2, and I've never seen him since, and he's just crushing it. He had a really good rad tech team. That helps a lot. So, all right, so we have another question. We have a joke question from Eric Folk, who's another F1 fan, and says, wait, why did you choose Ferrari? That's because he's a big Checo Perez fan. Anyway, we'll keep moving. Can you speak to the facility reimbursement increases? Do you see any of that in terms of, are we talking about just improved downstream revenue, or do you feel like you're making money off this procedure, or are you breaking even?
I think it's both, Mike. As I said, when we moved our navigation cases from endoscopy to hybrid OR, the level they were being billed for, the level 2 versus the level 3, the minor procedure and the major procedure, all those DRGs, again, I don't have hard numbers, but talking to the business people who run the program, definitely confirm that we were able to get more revenue and reimbursement for the case itself. And then this has definitely improved our overall volume, grew our program and procedure volume, and that in the long run feeds into the downstream revenue more and more.
Yeah, great. Another question is, are you able to navigate to the segmented lesion under the same positive pressure utilized during cone beam CT scan acquisition?
Well, we have to make the patient breathe once we obtain the CT images, and that time our pressure is kind of, we are holding the breath at about 25-35, so it's kind of unrealistic to maintain that throughout. And then also, so I would say the best way to guess would be to maintain a medium, medium level of PEEP, and then navigate, and then also utilize the real-time imaging to see how much variance you're getting, and that also is lobe dependent, where the lesion is, all that factors matter. But I don't think we can maintain a breath hold pressure throughout the case.
Yeah, I agree with you, and you really don't need to, right? So we keep PEEP on, so positive end expiratory pressure of 10 at least in all of our cases, and use that during your entire navigation, but you certainly can't do a breath hold during that. Your breath hold is really just for like 10-12 seconds when you're doing your 8-second spin. But remember that your breath can be held at any time you want. So if you have a lesion that's moving a lot and you want to hold it during your biopsy, you can certainly do that, and we do that a lot. But there's really no indication to do a breath hold or anything like that during the navigation process. All right, a couple more questions. Do interventional radiology techs run the cone beam CT? And if so, is this supported by your interventional radiology docs? Go ahead and give your answer, and then I'll give mine.
So we have always had radiology techs that run the IR program, and then also come to the advanced, the pulmonary cases and the GI cases. So we have kind of a common pool of techs. We have not utilized our IR physicians in any of our cases, never had to. But as far as a tech, we have a common pool. So that's the situation I have here, but it can be different at different institutions.
Yeah, so at my site, we just trained our regular rad techs who, shoot the C-arm during ortho and whatever. And we taught them how to do this. And so we have a core group of about 3 of those, and we always have one of those. We don't need the IR techs. They stay in the IR suite. That would be a disaster if we had to pull them out. And so in any case, I think that you can train anybody to do this. I had to learn how to do it myself, which I think is very valuable. And so a lot of the proctoring also, we want to teach the physician as well, because it's good for me. So if there's a problem, or if I have a new rad tech, I can troubleshoot. I know kind of exactly what to do. But we keep it to about 2 or 3 different people that we've trained on this system. We have cheat cards in case for some reason some newbie gets thrown in there, and we just make it easy. But we're not using the techs that cover IR cases. Did you have to retrofit your hybrid OR with a new cone beam CT? And what are the dimensions of your hybrid OR?
So my hybrid OR was built around this new system, and so my room and our system was built in 2017, so everything is new. So I did not have to do that, and the room is huge. I think it runs like 40 feet, 45 feet, and that doesn't even include the work rooms on either end. I mean, there's a lot of room here. I mean, I have to shout from one end to the other. It's that big, but again, it's very, everyone would be in a different scenario.
Yeah, and so these rooms come in all different shapes and sizes, so for example, we have an older system that's 11 years old, and we're in the process of upgrading to a new Azurian system, specifically that's something called the Special Lung Edition. And that was a pretty nice thing to be able to do, because that's a system that's dramatically less expensive than like the system you have. That flex, I mean, you literally have the Ferrari, the Flex Move system, the Azure, he's got everything. And so they realize that not everybody can afford that. So we're actually upgrading our room to a much cheaper system, and it takes the same footprint, the same size of the room. And again, that also allows for these to be an even smaller room. So I've seen pretty small hybrid rooms, or even bronchoscopy suites that are a little bit larger than your typical bronchoscopy suite, so not quite a hybrid OR, but big enough that they can just mount this system in there. The Philips systems come in both a ceiling mounted, or you could get a floor mounted as well. All right, so I think that's about it. Are there any other questions? Throw them into the chat box here real quick, and we'll see. There's a last comment / question. Thanks for a wonderful talk. What would you suggest are high yield topics for fellows and anyone interested in understanding the nuances of endoscopic therapeutics like ablation? Any suggested resources? That's a great question. I think that what you need to do is really start with percutaneous and learn about the technologies that are out there: radio frequency, microwave ablation, cryoablation. Figure out what those differences are, and then there's a sparsity of literature out there on transbronchial, and again, it's because we just haven't gotten to that point yet. There are some abstracts that have been published, but really talking with companies that you may be working with. So again, Medtronic has ablation. You can talk with them to learn more information about it. They have some fantastic people. New Wave does ablation as well, and they work with Johnson & Johnson, so your local Monarch or Oris rep may be able to talk with you about that and get some more information. But really just getting out there and searching online for some papers and studies, and then honestly going to talks like this. I will say that one caveat is be careful of who's talking. We go to some of these big conferences, and people that are lecturing on ablation have never done it before in their life. So sometimes consider the source of the information. But the short answer to your question is the Society for Advanced Bronchoscopy. We want to be the answer to that and your resource for your fellows, which are free to join, by the way. And have ongoing content on this information, just as we've done. So stay tuned and join SAB, and we'll keep bringing you that information. Dr. Sharma, I'd like to sincerely thank you for joining us tonight and giving us a fantastic talk about how you built your program. We look forward to seeing you on the next webinar. Thanks again to Philips for sponsoring this, and I hope you all have a great evening.
Thank you, Mike. Thank you for the opportunity.
Anytime.